This recording is part one of the Midas Mission 2.0 seminar meeting held on November 11, 2015. Mission 2.0 is the organization within the Midas Research Network for training of developers and customers on topics related to productization of software. The Mission 2.0 seminar series is a periodic informal event intended to educate and stimulate conversation amongst members. To become a member of Mission 2.0 and stay informed of all of our activities and events, send an email to the address listed at the bottom of the screen. This seminar was given by Dr. Samuel Scarpino on the topic of disease surveillance in lower socioeconomic populations. Dr. Scarpino is an assistant professor of mathematics and statistics at the University of Vermont and an Amid-Yar postdoctoral fellow at the Santa Fe Institute.
Great. Well, thanks for the introduction, and thanks everyone for attending. Can you hear me okay?
Yep.
Great. So I am going to talk mostly about recent work we've done on surveillance along socioeconomic gradients in Texas, but I wanted to give a slightly higher level overview of where we've been heading in the last couple of years on the design of multi-objective surveillance systems. And I think many of you have probably seen similar slides to this one, either by me or by Lauren Myers. And really what we've coalesced around is when we're thinking about designing surveillance systems, we want to imagine a four-step program. The first is to formalize the public health objectives. And what this really means is to come up with mathematical definitions of various public health objectives. And we think this is important because it allows us to compare different candidate surveillance systems or different data sources in some sort of rigorous mathematized framework that allows us to actually make a statement about whether a particular set of data are better or worse than a different set. The second step is to specify candidate data sources and acquire them. I'm sure as many of you know, this is often one of the major hurdles to designing surveillance systems, whether you're using internet-based data or traditional data. Step three is to simulate data where it's missing. So in many cases, it may be possible to come up with a plausible simulation scheme for simulating data where it's missing. And then the fourth and final step is to select the most informative data sources. And if you've done step one strategically, then step four can be accomplished. If you haven't been strategic about step one, then selecting the most informative data sources can be a serious challenge. And from sort of a computer science perspective, step four and step one are sort of where things are often the most interesting. And the last piece of step four, and this emerged from a workshop that I organized with Ben Althaus at the Santa Fe Institute on next generation surveillance systems, is that we noticed that there's often not a sufficient amount of validation being done on some of these new data-driven surveillance systems. And so we want to make sure that we're following both best practices in machine learning, but also best practices in public health surveillance for validation. And this slide that I'm putting up now usually comes towards the middle or end of the talk that I've been giving on influenza surveillance, but I'm going to use it to motivate our interest in multi-objective surveillance. So the first work we did in Texas for influenza surveillance was trying to maximize situational awareness. And the way that we did this was to try to maximize an R squared, or the amount of variation explained in some goal time series. In this case, it was statewide hospitalizations, using proposed surveillance sites, using influenza-like illness providers. And what occurred to us partway through this project is that if we also care about early detection, so detecting early cases, that maximizing an R squared or maximizing some metric of situational awareness might not be the best strategy for also maximizing the probability that you detect early cases. And it turns out this is the result we found. So we call the network that we optimize for situational awareness the one that maximizes an R squared. We call it the R squared network. And what we're looking at here are the number of early influenza cases that fell in the catchment area of our providers. So these are the providers we've selected for our surveillance system, the number of early influenza cases during the 2009 pandemic that fell in the catchment area. as a function of the size of the network on the x-axis. The situational or R-squared network is the lower gray-black line, and you can see that that does not do a great job of picking up early cases. And for those of you familiar with trying to maximize the variation explained, this might make sense, because one of the things that happens is we end up placing a lot of providers in rural and suburban areas where far fewer early cases occur. The orange line is a network that was specifically designed to maximize early case detection. In particular, it's designed to maximally cover the population of Texas. This was an algorithm suggested in a paper by Paul Green et al. In 2009. And as you can see, this does substantially better, basically at all provider sizes at picking up early cases. So what occurred to us is, could we try to simultaneously maximize early detection and situational awareness? And what ended up being convenient is that maximizing population coverage and maximizing an R-squared are both submodular optimization functions, which means that we have, submodular objective functions, which means we have a guarantee about diminishing returns as we iteratively select providers with a greedy algorithm. And so if we take a simple linear combination of these two functions, the early detection function that maximizes population coverage and the situational awareness function that maximizes an R-squared, that linear combination is itself going to be submodular. And so we can, again, use a greedy algorithm to select providers, and we will retain the same guarantee about the quality of the solution we're going to find. So for this first iteration, we just place a 50% weight on early detection and a 50% weight on situational awareness. And these are the results. We creatively called this new network mixed. This is the gold line. And what you'll notice is that at higher provider counts, starting at about 75, the mixed network is actually predicted to catch more early cases than even the early detection was. So what's the intuition here? Well, the intuition is that the early detection network is maximizing population coverage. And so it's really doubling down on the urban centers. And that is where most of the early cases occurred. But of course, some early cases are going to occur in comparatively more rural or suburban areas. And because the mixed network is trying to also optimize an R-squared, it's placing some of these providers in these suburban and rural areas. So it actually ends up picking up more cases. The other thing that we can do with such an approach is we can benchmark the existing performance of ILINet. And we've found through our work with Texas that this benchmark feature is one of the things that they're most interested in. So some of you probably heard about our work trying to optimize the placement of the state's strategic stockpile of antivirals to maximally cover the underinsured. And what Texas has mostly used that algorithm for is to benchmark how they did during the 2009 pandemic. And so what we can see with the blue dot is this is the provider size for the ILINet, about 82 providers, and that was predicted to include about 400 of the early cases. So you can see that the ILINet is predicted to have outperformed just the situational awareness network, but is predicted to underperform networks that were specifically designed to pick up early cases. We have similar results for situational awareness. So again, the lines are the same. The orange-red is the early detection network, maximizing population coverage. The black is the situational awareness network, maximizing an R-squared. And the gold is the mixed network that places a 50% weight on both of them. Again, the blue dot is the observed performance of the ILINet. We have the proportion of variation, so this is the R-squared as a function of the number of providers. And the way that we actually calculate this R-squared is we construct a network on an in-sample of providers up through the end of the 2009 seasonal flu outbreak. We fix those regression coefficients, we fix the providers that we've selected, and then we evaluate the performance of this network against the 2009 first and second waves. So these are actually out-of-sample performances. That's both why you see the lines being so jagged instead of smooth, and why you see diminishing returns as we increase the number of providers. So interestingly here, The situational awareness network performs better at basically all provider levels, although the mixed network performs substantially better than just the early detection. And the ILI-net is predicted to perform just about as well as the early detection network, but again, worse than networks that were optimized for situational awareness. Since then, we've worked on dengue surveillance in Puerto Rico, and this is in collaboration with Michael Johansson at the CDC. And for the Puerto Rico question and for dengue, we actually have a whole suite of objectives that we're trying to simultaneously optimize. So this includes island-wide dengue incidence of each of the 4 dengue serotypes, incidence in each of the 8 health service regions, and incidence in each of the 80 municipalities or counties on Puerto Rico. And so we have a much higher dimensional space of objectives that we're trying to simultaneously optimize. And we ended up learning something kind of interesting along the way that I'll just share with you here very quickly. So the y-axis is the average out-of-sample R-squared for 100 out-of-sample tests. And so basically the way that this works is we have a 15-year time series. We excise 3 years from that time series. We train and build the model on 12 years and then evaluate on the 3-year held out sample. And we do this 100 times where we pick 100 different 3-year chunks. So what we're looking at, this is the average out of sample R-squared against island-wide incidence. And so the first network is the network that was optimized against island-wide incidence. And you can see we achieve very high performance, and it's the best of all the networks I'll show you. The second best network is the network that was simultaneously optimized against all of the objectives I just listed. And what's kind of cool is that this multi-objective network is always the second best network for any objective. The best network is always the one that was optimized for that specific goal, and the second best is always the multi-objective network, which tells us, at least for dengue, like we saw for flu, we can construct these multi-objective networks that don't sacrifice too much in performance. Next, we see, and again, this is always the third best network, and this network was not designed using historical dengue data. So we wanted to try to explore other procedures for optimizing surveillance or enrolling providers that don't rely on historical data for the disease. And so we tried the similar metric where we just maximize population coverage. I'll show you that actually performs the worst of all the networks. We tried one where we try to maximize patient volume, so we know how many patients come through each of these providers. And again, that doesn't perform particularly well. But we have an additional piece of data, which is we know the municipality of residence for each patient that comes into a provider. We call this network diversity because what we're doing is essentially maximizing the entropy over the patient residence distribution. So we want to select providers such that we see patients from as many different municipalities in as equitable a way, as uniform a way as possible. And it turns out that by selecting providers using this diversity metric, we can do almost as well as if we use historical data to optimize our network. The next networks we see are those optimized for regional, serotype, surveillance, and then, as I mentioned, volume, so the total patient volume, and then population. And we see these results repeated across both the regional, the serotype, and the municipality surveillance. So now what I'd like to do is switch gears and talk about a specific study that we've been working on. And this is a study of how to perform surveillance along socioeconomic gradients. One of the nice or interesting or disturbing findings that I came across while I was thinking about this research and how this research fit into our broader understanding of the relationship between socioeconomic factors and disease, or income inequality and disease, is that our understanding goes basically all the way back to what most of us would consider the first epidemiological study. This is John Snow's 1855 study of a cholera outbreak in central London. I'm sure the map that you're looking at is familiar to everyone. So dots are cholera cases, X's are wells, and the X there that's a little bit hard to see on Broad Street is the well that we now believe was contaminated with cholera bacteria. About 50 years later, another John Booth, published the first high-resolution neighborhood by neighborhood, block by block map of income, and again for London. And so we're looking at a snapshot of this map that's again zoomed in on the Golden Square neighborhood of London. And what you can see is that the map moves from wealthy and gold through red to purple to blue to black, increasing poverty as we move towards this black X in the center, which is the Broad Street water well that was contaminated with cholera. So going all the way back to the first epidemiological study, we have some hint that there's an association between poverty or inequality and disease. And this, of course, has been borne out in the last 100 years of research on infectious diseases. So this is modified from a paper by Shi et al. In 1999, and you can see that income inequality, this is a path analysis, income inequality has a direct effect to reduce life expectancy and an indirect effect to reduce life expectancy through reduced access to primary health care. So the first study that I'll talk about is work that I've done in collaboration with the City of El Paso Health Department. And in particular, they were interested in the following time series. So we're looking at the number of rapid positive tests for influenza sent into the City of El Paso Health Labs during the 2013-14 influenza season. So the y-axis is the number of positive tests, and the x-axis is the date going from October through April. Now, one of the reasons that El Paso is so interested in this is the same reason that a lot of public health labs are, is that they're totally overwhelmed by these rapid positive tests. And in addition to that, I didn't use the number of rapid positive tests for any nefarious reason. I used it because we don't actually have the denominators. So they get sent, the public health labs are sent these rapid positive tests, but they're not told by the testers how many tests they actually ran. They just get the number of positive tests. So one of the things that we wanted to try to understand was what is contributing to this time series? Where are these tests coming from? Can we learn anything, for example, about this second peak that we see towards the end of the flu season? It actually turns out to be flu B. And what we looked at was the relationship between poverty and flu positivity in El Paso. So we're looking at here is a map of El Paso County. You can see it's the western tip of Texas. And these are zip codes colored by the proportion of the population living below the poverty line, going from some zip codes where no one lives below the poverty line to some zip codes where 65% of the population is below the poverty line. So what we did is we took the time series of rapid positive flu tests for each of these zip codes, and we asked whether there's any evidence for synchrony between these zip codes. Are these zip codes cycling together with respect to flu? Are they in phase? Are they out of phase? Are there distinct clusters of zip codes that are cycling together? And the answer turns out to be there are two very strong clusters of zip codes that cycle together with each other. There's the blue cluster, so I've colored those zip codes in blue. Each zip code has a dot in its center. And then there's a red cluster. I've colored them in red. And so what we wanted to try to do was to ask what predicts membership in these blue or red clusters. So the first thing that we tested, and you might be able to guess the results just by looking at it, was whether geographic proximity predicts membership in blue versus red. So I just did a simple principal component analysis to project latitude, longitude onto a single axis so that we could view it more simply. And what you can see, so this on the y-axis is the score for each zip code on this one-dimensional axis. And I've colored, again, the zip codes in blue and red. And you can see that we basically get no separation whatsoever. So there's really no predictive power based on geographic proximity. However, if we look at the proportion of the population in poverty, you can see that we do, in fact, get some separation between blue and red. And it actually turns out with about 75% accuracy, we can classify zip codes into blue or red just based on the proportion of the zip codes that are in poverty. We see a similar relationship with proportion vaccinated, that again, if you know the proportion of the zip codes that are vaccinated for influenza, we can classify with about 75% accuracy which cluster you're going to be in. Now, interestingly, there's no significant interaction between proportion vaccinated and proportion in poverty. So we don't get any additional information because they're almost perfectly correlated with each other. So the wealthiest zip codes have the highest vaccination rates and the poorest zip codes have the lowest vaccination rates. Sort of a sidebar that I find kind of interesting is that you look, and most of these zip codes have 30 to 50% vaccination coverage, but we still see influenza outbreaks, which tells us almost assuredly that our mass action models used to estimate the reproductive number are not giving us a good sense for what vaccination coverage needs to be for herd immunity.